Thank you for this opportunity. I always enjoy this meeting. It's a wonderful multidisciplinary educational event for me, at least. So, talk a little bit about how I treat the aorto-iliac system, particularly more of the distal system. As we all know, aorto-iliac occlusive disease, whether treated open or endo, really has very durable results, and we offer it often to both claudicants and patients with chronic limb-threatening ischemia. We know that aortobipham disease does have very durable results and very long-term durability. However, they do come with some upfront costs with regards to morbidity and mortality, and we've really kind of taken a shift with regards to our approach to this as an endovascular first in this more inflow treatment algorithm. You can see multiple different societal guidelines does approve an endovascular first approach. So you can see that the 2016 AHA guidelines recommends a endovascular first approach, and the recent European societal guidelines actually, the way that they word it is, if a patient's a low risk, you can consider them for an open bypass, which I think is a dramatic shift in how we've thought about things. Again, supporting an endovascular first approach because of the increasing technologies we have to be successful for this. This was also supported in the SVS global guidelines, and then in the SKY guidelines they go even further into recommending different types of therapies for different lesions. And while the level of evidence supporting this is variable, what we can kind of agree on is that aorto-iliac bifurcation disease and focal common iliac disease, as there's strong level 1 support for balloon expandable stents for both covered and uncovered, and then when there's a moderate or severe degree of calcium, really supporting those covered stent utilization due to the data, some of the data that we'll go into, but owing to these very complex aorto-iliac reconstructions, we have an increased patency with regards to covered stenting versus bare metal stenting. So for me, when I treat aorto-iliac disease, I always get a CT scan. I think this completely prepares you for what you need to do. So you're allowed to see, this allows you to see the anatomy of your aorta, your iliac arteries, but also to pay really close attention to your common femoral arteries. I think this is very important when we're thinking about flow into the pelvis, particularly if we're treating claudication of the buttock or the thighs. Knowing the status of the profunda and how we revascularize that is critical, and also keeping our aorto-iliac intervention patent. It also gives us calcium morphology, our reference vessel diameter size, and also can indicate if you have aneurysmal disease that you may need to concomitantly treat that you may underappreciate on an angiogram alone. Again, taking a look out for those critical collaterals, whether it's the internal iliacs, your profunda, your lumbars, your circumflex iliacs, or your IMA, really knowing how the underlying pelvic and leg collaterals are feeding each of these vessel beds is critical so you don't injure these in your reconstruction. So for me, as I work my way down, and I'm thinking about how I treat, I start up most proximally and work my way distally. So if I'm dealing with occlusions or stenosis in the infrarenal aorta, I'm considering either a CRAB or an aortic endograft if I'm getting about 2 to 3 or 4 centimeters above the iliac bifurcation. Once I get to the aortic bifurcation, and I'm just pretty much treating right kind of that spillover disease at the bifurcation of the aorta, I'm typically doing kissing iliac stents, and in this situation, I'm using covered balloon expandable stents, and we'll go into that in a minute, but really for ease of repeat intervention, and then because of the increased patency rates that we see in multiple different studies in these kind of complex iliac lesions. When we start to go into the common iliac lesions, balloon expandable stents, sometimes there's a role for a bare metal balloon expandable stent if it's a very short lesion kind of in the middle and not going to interact with the bifurcation, but often I'm using covered stents in these situations as well. In the external iliac, we start to think about a different variety of treatments, right? So we could use covered stents if it's a long CTO, or potentially bare metal stents if it's a short focal lesion, or if you maybe need to cover the internal iliac artery, you may want to use that as opposed to covering that and losing that internal iliac. And then I am a big proponent of common femoral artery treatment. I prefer significantly endarterectomy over endovascular, but there is a role in endovascular in some sicker patients. Moreover, what we can see is that for IVL has really kind of changed the game, and if I'm seeing any kind of moderate or severe occlusive disease, I'm going to be going ahead and using IVL as well as an adjunctive treatment. So I really am a big proponent of liberal use of common femoral endarterectomy. I think we tend to underappreciate the disease in the common femoral, and we also need to have direct revascularization of the profunda in order to treat the underlying pathology, not only for buttock claudication, but if you have downstream SFA disease, and it's also improving your long-term patency. So here's a CT scan where maybe we might say we can get a sheath and we can go ahead and not treat this common femoral artery, but when you open these arteries up, these are highly occlusive lesions. They're popcorny, they're eccentric, and really can inhibit your outflow of your intervention. We also know that there's data to support that the robustness of your profunda not only increase your long-term patency, but also help have your stents have a long-term durability as well. So here's a 72-year-old male with a history of hypertension who had claudication, had a prior fem to bypass with significant femoral disease there. So ultimately underwent a right femoral endarterectomy with kissing iliac stents, and you can see we utilize a steerable sheath to come up and over in order to engage in the true lumen proximally. Using a rendezvous technique, we can get through and through wire access and utilize kissing stents, and then a Viabond into the common femoral artery on the right side into the prior patch with a very nice result. I also am a big proponent of IVUS. I think that this is a great way to know what you're dealing with once you start to intervene. So how deep is your subintimal tracking if you are subintimal? Where's your exact location of your reentry? So that may help you choose what type of stent you want to use. If you haven't had a preoperative CT scan, it's critical in giving you your appropriate stent sizing, and also the kind of the quality of your calcium and whether you do need to use IVL or not. There is an expert consensus that does support the utilization of this in aorto-iliac reconstruction, and I use it liberally as well. There's some complications that I look out for when treating this. The most feared one, obviously, is going to be a rupture or a perforation that you can't bail yourself out of, and so using covered stents really does help kind of mitigate that. So in these more complex lesions, aortic bifurcation lesions, or things that are really highly calcified, I tend to lean towards covered stenting because of a couple of reasons. Not only are you going to decrease your in-stent restenosis, and we have data to support that, but you're also potentially going to decrease your risk of ruptured aneurysm, of rupturing or perforating your vessels. You're also probably going to get a little bit better stent expansion. I feel a little bit more comfortable taking my stent to its full potential when I am covered, as opposed to if I'm using a bare metal stent in some calcified disease. And then this can also facilitate future interventions. If you're doing kissing stents, it can be very difficult to come back up and over through bare metal stents in the future. Cobest has been touched on, but obviously this demonstrates in the complex lesions. Task C and D, covered stenting has far superior patency with regards to aorto-iliac reconstruction as opposed to bare metal stenting. There's also meta-analyses that also support this as well. This meta-analysis from 2021 of 47 studies, again, confirms in task C and D lesions, the primary patency of using covered stents over bare metal stents really does portend a much significantly improved patency rate of 92% versus 75% in the long term. IVL, I think, is a big game changer, and I think it helps us really modify both concentric and eccentric calcium so that we can get our stents to our full potential, and we feel comfortable doing this without risk of rupture or perforation. And what you can see is from a sub-treatment of the Disrupt PAD3 trial, looking specifically at aorto-iliac treatments, you can see that a fair amount of stenting was used, but the rates of perforation and dissections were exceedingly low, demonstrating that this is a safe adjunctive technique we can use when we're reconstructing these kind of tenuous patient population. So this is a 65-year-old female who I treated for blue toe syndrome, who also had underlying disease from her iliac arteries and also some aneurysmal disease, a small calcified aortic bifurcation and an eccentric common iliac artery lesion. So you can see here on this IVUS run, while the aorta itself was circumferentially calcified, as we get down into the bifurcation, it's very tight, it's very calcified, both eccentric and concentric. So we can start here on the right, where I start once I've crossed with an L6 8mm device, and you can see the very big dog boning at that origin, and then that relieves as we start to balloon it, giving us a nice lumen and allowing us to have a nice stent apposition of our AFX at that point. CRAB is another option if we start to extend 2 to 3 to 4 centimeters above the bifurcation. It has very durable patency rates, and it allows to eliminate some of the guttering that you can potentially have with long kissing stents that are built up quite high into the aorta. Other studies have looked at the primary patency rate out to 3 years being almost 100%, which is quite excellent in a very complex patient population. So for the sake of time, we'll move forward. The only thing that I would say is that one of the techniques that I have converted to in these situations is more of an eye of a tiger to create a D-ring technique. So I go ahead and I put my VBX in proximally, I post-dilate to the appropriate size of my reference vessel aorta, and then I will put my two VBXs up there. I will post-dilate and overexpand my one, crushing the one side, and then I will inflate the other one in order to get a nice D-ringed effect. So I've really kind of eliminated any of that gutter space to try to maintain my luminal flow. The only other thing I just suggest is when you're doing this to be aware of your collaterals. When you're doing this, this is great brought up in our live case today about preserving the IMA. You want to be aware of, is the SMA patent, is the IMA patent, has the patient had prior colon procedures, and what is your status of your profunda? And if you need to maintain that, do not hesitate to maintain your internal iliac artery with placing an uncovered stent across it or placing a gap in order to maintain that pelvic perfusion. So thank you very much for the opportunity, and I look forward to any further discussion.